So I would also like to welcome you all to this very interesting session. We will move on to the next presentation regarding cardiac involvement in seronegative arthritis. It will be presented by Dr. Venetsanopoulou. She is a rheumatologist and also a postdoctoral researcher in the Faculty of Medicine in the University of Ioannina. Mrs. Venetsanopoulou, welcome, and we are looking forward to your presentation.
Good afternoon. My name is Venetsanopoulou, and it's my honor to share with you today some key insights on cardiac involvement in inflammatory arthritis, with a particular focus on seronegative arthritis. As rheumatologists, we are often at the center of managing systemic inflammation, but we must also remember that our patients' hearts are often quietly affected. Today, I hope to highlight why this matters, what mechanisms are at play, and how we can better detect and manage cardiovascular risk in this population. So, here is the roadmap of my presentation. We will begin with a definition of seronegative arthritis, then move to cardiac complication and why they matter. We will examine how inflammation contributes to cardiovascular risk and review the immunological mechanisms linking chronic inflammation to cardiac pathology. And from there, I will highlight screening strategies and management approaches, including the critical role of the rheumatologist in cardiac care. Finally, we will touch on future direction before drawing some conclusions. When we talk about seronegative arthritis, we refer to a group of inflammatory joint disease that are negative for rheumatoid factor and anti-CCP antibodies. The major types include psoriatic arthritis, ankylosing spondylitis, reactive arthritis, and enteropathic arthritis. These conditions we know well that share some common features: enthesitis, dactylitis, and a mix of axial and peripheral arthritis. Extra-articular manifestations are also frequent, such as uveitis, skin psoriasis, and inflammatory bowel disease. Importantly, cardiac involvement, though often subclinical, remains under-recognized. The prevalence of seronegative arthritis is about 0.5 to 1% of the general population, and there is a strong association with HLA-B287, particularly in Northern Europe. Ankylosing spondylitis, Ankylosing spondylitis shows a male predominance, while psoriatic arthritis is more balanced, sometimes even female predominant. Now, why does this matter? Patients with spondyloarthritis face a cardiovascular risk that is about 1.5 to 2 times higher than the general population. In ankylosing spondylitis alone, the risk of heart disease is elevated by up to 40%. The reasons are multifactorial, as we will talk, but the problem is that the result is that the cardiovascular events present earlier in life, and cardiovascular mortality remains one of the leading causes of death in these patients. So, looking at condition-specific outcomes, in psoriatic arthritis, the risk of myocardial infarction is up to 55% higher, closely tied to metabolic syndrome. In ankylosing spondylitis, we often see aortic root disease, atrioventricular block, and even sudden cardiac death. In IBD-associated arthritis, ischemic heart disease and stroke risk are increased. And for reactive arthritis, data are more limited, but chronic inflammation likely plays a role. What is clear is that across the spectrum, cardiovascular involvement is not the exception, but a defining comorbidity. Moving to pathogenesis, we now understand that joint and cardiovascular inflammation share some overlapping pathways. We know that in ankylosing spondylitis, immune-mediated fibrosis explains why the aortic root and conduction system are so frequently affected. So far, studies have shown that pro-inflammatory cytokines like TNF-A, IL-17, IL-23, and IL-6 not only drive synovitis, but also endothelial injury, vascular stiffness, and plaque instability. New data show that Th7 cells amplify IL-17 signaling, macrophages, and dendritic cells that infiltrate vessel walls, and chronic cytokine exposure impairs nitric oxide production, leading to arterial stiffness. So, we said that there is chronic systemic inflammation, there is immune cell activation, but there are three other mechanisms that we need to highlight so we can understand better the pathology. First, we know that oxidative stress, where reactive oxygen species are potent mediators of vascular injury, and they drive vascular remodeling and tissue damage, disrupt endothelial integrity, and stimulate smooth muscle proliferation. Over time, this burden transforms the vascular tissue from a state of adaptation to one of chronic injury. Second, we have the lipid metabolism dysregulation in those patients. Inflammation changes the normal balance between HDL and ADL. This shift towards a more atherogenic profile accelerates plaque development and directly links immune activation to a metabolic dysfunction. And third, there is a macrovascular inflammation. This involves a continuous interplay between endothelial cell and cytokines, creating a cycle of injury and impaired repair. As a result, myocardial perfusion becomes compromised. Together, these mechanisms show us that cardiovascular disease in seronegative arthritis isn't an isolated complication. It's an extension of the same systemic inflammation process that drives joint disease. So, moving to diagnosis, we know that the diagnosis is challenging because cardiac involvement is often silent. A combination of clinical suspicion, imaging, and biomarker is essential. There are routing tools which include ECG to detect arrhythmias and conduction delays, and echocardiography to assess valve dysfunction and wall motion abnormalities. However, this often miss early disease. Cardiac MRI is quietly powerful. It's able to detect subclinical myocarditis and fibrosis before symptoms progress. Cardiac ultrasound may also reveal early atherosclerosis. And, in terms of biomarkers, today we use high-sensitive CRP, troponin, and proBNP, which are useful, though they may be confounded by systemic inflammation. We hope in the future that emerging markers like IL-17 and IL-6 may one day bridge the gap between systemic inflammation and cardiovascular pathology. So let me share with you one of the key studies that highlights the role of CMR in inflammatory joint disease. This was a prospective evaluation of patients with rheumatoid arthritis, ankylosing spondylitis, and psoriatic arthritis who presented with symptoms such as shortness of breath, palpitation, or chest pain in the previous few months. Importantly, all of these patients had normal clinical evaluation, ECG, laboratory workup, and echocardiography. In other words, using conventional tools, we might have dismissed their symptoms. There were a total of 51 patients with preserved ejection fraction, 32 with rheumatoid arthritis, 10 with ankylosing spondylitis, and 9 with psoriatic arthritis. For comparison, we used 40 healthy controls of similar age and sex who also underwent CMR. They all, you see here the basic characteristics of the cohort. I won't go to details, but we have to take account that they had very low percentages of comorbidities, such as hypertension, hyperlipidemia, and diabetes. And we used for all of them a comprehensive CMR imaging protocol using at both 1.5 and 3 Tesla scanners with techniques including sign imaging, T1 mapping and T2 mapping, and gadolinium enhanced imaging. And so what we found is that compared to controls, patients with inflammatory arthritis had a higher native T1 values and higher T2 mapping values consistent with myocardial inflammation and edema. They also had a lower post-construct T1 mapping indicating diffuse fibrosis. These abnormalities were present even when routine tests were normal. What's especially striking is that these findings did not correlate with disease duration. In other words, the cardiac involvement was not simply a late complication. It could present at any stage of the disease. And so what does this mean to us? First, it highlights that subclinical myocardial injury is common in patients with inflammatory arthritis who present with symptoms but have normal routine tests. And finally, it suggests that early use of CMR, it's an expensive test, may allow us to detect and treat cardiac involvement before irreversible damage develops. Of course, this study had a lot of limitation. We had a small sample size, we had referral bias, and lack of long-term follow-up. But the key message, I think, was very powerful. If we rely only on echocardiography and ECG, we will miss important cardiac pathology in our patient. And moving on to management, this is why management of seronegative arthritis cannot stop at the joints. We need to screen thoughtfully, collaborate, and use advanced imaging when it is indicated. That way, we can intervene earlier and reduce cardiovascular morbidity and mortality at this high-risk group. So, how do we act with this knowledge? The answer lies in a structured approach. When we think about seronegative arthritis, we rheumatologists often focus on the joints, but we also need to focus on the heart. Cardiovascular risk in this patient is high, under-recognized, and oftenly undertreated. That's why taking action really matters. We start by looking at traditional cardiovascular risk factors, smoking, high blood pressure, high cholesterol, and diabetes. Identifying this risk earlier gives us the chance to intervene before serious complications develop. Some patients we know that are particularly at high risk. These are individuals with multiple risk factors, those with long-standing or severe arthritis, patients who have had long-term use of steroids or NSAIDs, or those with family history of heart disease. For these patients, we monitor more closely with regular blood tests and imaging, and sometimes we use advanced tools like cardiac ultrasound to detect if there is something very early. The goal is simple: to catch problems before they become irreversible. Controlling inflammation is also central to protect both joints and the heart. We heard about biological treatments such as TNF inhibitors. There are also IL-17 and IL-23 blockers in seronegative arthritis that help reduce arthritis activity and lower cardiovascular risk. At the same time, medications like glucocorticosteroids and NSAIDs need to be used with caution because they have potential effects on the heart. This is not something, of course, that a single doctor can manage alone. Rheumatologists, cardiologists, radiologists, and primary care providers must work together as a team so we can ensure that the patient receives a comprehensive care for both joints and heart. So there are guidelines, and we use them, and we have borrowed some of the guidelines from rheumatoid arthritis. Those guidelines have some main principles, like that cardiovascular risk extends beyond rheumatoid arthritis. We know that very well, that the rheumatologist has a key role, and we must be very, very cautious, as I said, when we select antirheumatic therapies that have cardiovascular effects. What we know today and what we use in clinical practice is that we have to repeat cardiovascular risk assessment at least every 5 years or sooner if we have major changes in therapy. Risk calculators are useful, but we must remember to adjust for the added risk that inflammation brings. Controlling disease activity early and tightly, minimizing the flares and the cumulative inflammation is a powerful way to reduce cardiovascular risk. And at every step, collaboration across specialities is something that we need to focus on. Of course, medications are only part of the picture. We have to remember always lifestyle remains a cornerstone. Quitting smoking, eating healthy diet, exercising regularly, and maintaining a healthy weight all make a real difference. Equally important is empowering patients' education and engagement that improves adherence and long-term outcomes. So, looking ahead, the future of cardiovascular care, I think, for seronegative arthritis is exciting. AI-assisted cardiac imaging will help it detect heart changes earlier. New biomarkers and genetic profiling may also help us to identify high-risk patients before complications present. Clinical trials now are evaluating cardiovascular outcomes in new biologic therapies, and of course, we need long-term study to help us refine predictive models, moving us towards truly personalized cardiovascular prevention. So, to conclude, we must take account that seronegative arthritis is not just a joint disease. It profoundly affects the heart. We know that very well now. But with early detection, integrated care, and patient education, we can prevent irreversible cardiac damage. Collaboration between rheumatologists and cardiologists is essential, and with a team-based, patient-centered approach, we can protect both joints and hearts and make a really difference in the lives of our patients. Thank you very much.
Thank you very much, Dr. Venetsanopoulou, for the excellent presentation. I don't see any questions.
I have a comment.
Okay.
Okay. Thank you so much, Dr. Venetsanopoulou. It was an excellent talk, and you impressed all of us. My question is why, although there is such a high risk factor for coronary artery disease, you don't use routinely statins? And the second is, why do you believe that the cost of all these non-invasive exams is so high? Remember that if you compare it with clinical evaluation and management of patients with coronary artery disease or heart failure is much higher. So I think it's not correct if we say that the cost of imaging is high. The cost of treating patients is high, and we should prevent them from treatment for in-hospital treatment.
We cannot hear you, Mrs. Venetsanopoulou. Mrs. Venetsanopoulou, we cannot hear you. Turn on the microphone, okay?
So I agree with you for the second question. The cost of treating a patient is very high, and it's a great problem, but it's something that it's not from us, it's from the system of health that we can put additional exams. We have many problems. We can make some basic exams to our patients. We have limited access to many of the exams that you use as cardiologist. And regarding statins, I agree with you. but we need some trials that will focus on that. And of course, I expect the guidelines of 2026 to give us a very good answer to your question.
Maybe you have to ask to have an echocardiograph and a person from echocardiography in the rheumatic clinic just for everyday routine assessment. And then he will send the patients for further more sophisticated imaging.
Yes,
how do you find this idea?
I like this idea. You know, I want to collaborate and with you very much. But it's very difficult. The reality is that it's very difficult for other
maybe
factors.
you have to negotiate with a local cardiac clinic. This is not difficult.
Okay.
Maybe a cardiologist, they can come day by day and evaluate your patients. In any case, we need more collaboration between the two specialties, and for this reason, we propose the cardiorheumatology subspecialty, which will include both cardiologists and rheumatologists, and will make our life easier because it will be more interaction.
I hope for that in the future.
Okay, thank you.
I also think that it is very important to note that even if the first screening with an ultrasound is negative, but the patient continues to have symptoms, it is very important to refer for CMR.
Yeah.
Because there might be subclinical myocarditis, and this is very important to catch it in the beginning.
Great. You look that you are very experienced in this.
Well, with our patients in scleroderma, we have this problem very often.
Yeah, I know.
Yeah, and I would like to stress also the rule of corosity in these patients, because if we recalculate the risk, we can use drugs as statins without a problem. Because, for example, I don't know in Greece, but in Italy, we cannot use extensively statin if you don't have a demonstration or high level of LDL or a demonstration of a plaque.
Yeah, exactly the same in Greece.
Yeah,
if you have high cholesterol levels,
yes,
and many risk factors, it is allowed to apply statins, or even if you have plaques in coronarycity. But I think most of these patients have abnormal lipids, specifically patients with rheumatoid arthritis, not only with, this is not too much in systemic sclerosis, but in lupus and arthritis, yes.
Yeah, because also the target of the statin therapy can change. Because if you don't have a plaque, you have a target. If you have a stenosis, also a mild stenosis, you have to recalculate the target of the therapy.
Yeah, and also other parameters from CT. I mean, FFR, fat attenuation, all these which we don't calculate in routine. I mean, even CT technology, CT report, everyday CT report should be improved by including these parameters. I think so.
Yeah.
You are the specialist, but I think it will be an improvement in technique if we include all these parameters.
Yeah, and this is another important issue, because I don't know which is your clinical practice, but in all patients, but in particular in these patients, important to give in the report not only the percentage of stenosis, the grading of stenosis, but a plaque characterization.
Yeah.
It's really, really important.
Yeah, we do that. However, we miss the fat attenuation, which is very important, and the FFR. It's not part of routine. So I think radiologists should work in this field very much and give a more precise report with all these details.
Yeah. So we don't have other question from the audience. So last but not least,